Welcome to the most important, the conference was built from this, as Joe Biden says, from the middle class out, from the healthcare affordability panel on out. And in fact, FREOPP was built that way because Ovik began life as a had an important middle of his life as a healthcare policy expert. Our focus is going to be on affordability. FREOPP's thought has been that there's work that can be done to make the demand curve work. In healthcare, if a hospital lowers its price of its MRI, it doesn't gain any market share. And if it raises its price, it doesn't lose any market share. And the reason is, well, it'll all be revealed here in this panel, but one possible reason is because that lower price MRI, when a patient goes for it, the savings doesn't go to the patient. It goes up into the morass of cross-subsidized third-party payment and is lost as a source of value to the patient. And so the first argument is always, well, let's just let the patients pay for it all and it'll be much cheaper. But of course, as a wealthy society with a wide range of incomes, we are terrified of pulling the healthcare safety net away. And so we are constantly torn between Scylla and Charybdis. So what is all of our favorite vignette, favorite example of demand curve not working?
Well, I live in the Boston area where we have some well-known hospitals, and there was a state report that came out a couple years ago that was saying that roughly 40% of patients who came to downtown institutions drove past multiple other options in the suburbs on their way into town to go to these higher-priced institutions. So I think that it's not just one patient. There's a whole thousands of them who are making this choice to pilgrimage in to pay more.
That's a great one.
In my prior life as a consultant, we did a bunch of focus groups to understand how consumers select where they're going to do elective procedures. And, there is no Amazon 5-star review in healthcare that anyone trusts. And so to a person, everyone in the focus group says, well, if it costs more, it's probably better. And if there's a big billboard, then it must be good.
I think kind of expanding this out a little bit to prescription drugs. If you look at an example like Humira, a drug that's been on the was on the market for 20 plus years without any kind of generic competition at all. And, AbbVie sort of raking in the cash on that. I think people would be surprised to realize that the net price on that drug just across the market steadily increased over that time. A very large percentage of that drug's revenue over the 10-year period was simply from price increases. They did increase some of their revenue on that drug by adding additional indications over time. So they grew the patient population, but the amount that they were getting purely from price increases, we've done this research, it was the vast majority of that. And the patient largely doesn't feel that, in particular if they have a health insurance plan that shields them from that or has a low out-of-pocket max, because once you hit that max, you can continue taking that drug and it's going to be mailed right to your door at zero cost to you. And so that's a good example of how the patient just isn't feeling that.
Okay, so we have this, we've painted a picture. We have this toxic, we have drugs, hospitals. We didn't get into health plans, but there has been lots and lots and lots of work on affordability of healthcare. It is a national topic. It is probably one or two existential threats to the survival of the country, because if you draw the line of the cost of healthcare and it keeps going and you don't ever step back from it, it eats, cow eats world. What are your favorite, we'll start with Josh and work our way back. What are your favorite, of what has happened of late? Let's go as far back as Obamacare and then through a lot of the value-based care and Trump, and then all the way through to what may happen next. What are the things that give you the most hope that they may actually track and pull through value in the long term?
Well, I think there's a couple things that I hope they build on, and I've seen the most opportunity. So price transparency, which we can talk about, I think has real potential. But just having price transparency, as we've already kind of illustrated, probably doesn't solve the problem in and of itself. However, there's versions in which you start to think through how do you align incentives and actually reward the providers who are offering better care or more ethical pricing, if you will. And I get hope from two places. One is there's a number of states who have started to allow patients to pay cash and then still get deductible credit. It deals with some of these underlying issues, which we can go down the rabbit holes if you want to. And sometimes they actually even pay them to do so. So not only get deductible credit, but, oh, here's a little cash check. I think that starts to align incentives. The second one I do think is state employee plans, is that there has been some action in a few states to think differently about how to move forward. And the corollary in the private market is self-insured large companies. Some of them have been pretty innovative in this space. Direct contracting, medical tourism, kind of taking the bull by the horns, flying people to another state for surgery, something like that. I think state employees, there's been some activity, not enough, but some activity that does have positive ripple effects into the private market, where those that work for a mom and pop small business have new options in the state. Down the road, something opens because there is a platform, a marketplace that can be accessed when there's hundreds of thousands or millions, depending on the state, of state employees who have new program designs who are able to be driven to lower cost options.
I'm delighted that we are finally talking about prices after 10 years of talking about value-based care and determining that we don't know how to deliver better care at the moment. And that right now, I think actually there's an unprecedented agreement that the problem at the moment is the prices. Not that we're going to ignore utilization, but that actually we can go after prices and we need to do that aggressively. And that is a degree of complexity reduction that I think we really need at this point. Just clarity that right now, every actor in the healthcare system can more easily raise prices than find any other source of operational efficiency or value. And we have to change that, right? We just have to begin across the board to put downward pressure. I mean, you look at the MA market, and there's been lots of talk about how MA plans are going to manage care better, but mostly we've seen, aggressive rate arbitrage as we code up patients and increase revenue. And the same thing happens on hospital prices, and the same thing happens on drugs, as you pointed out. And so, if we can say we're not going to allow healthcare businesses, right, to make it easy for them to increase prices, they're going to have to innovate, right? We're going to have to figure out what the care model is. That I think can take us a long way.
I wholeheartedly agree with both of their sentiments. I too am encouraged by a lot of the action that's happening on the state level. Where I'm based in Austin, the Texas legislature recently prohibited several anti-competitive contracting practices at hospitals, pretty much force on insurance companies. That's an important cog in that wheel of being able to, for the insurance companies to be able to not only negotiate a fair price, but also to inform their beneficiaries of where they can seek that higher value care. So I think that's one important thing. I think another thing, to go on Josh's point with some of these state employee plans, we're seeing action recently, and this is happening too in the private market, where some of these innovative benefit designs where some plans are able to employ something like reference pricing, where it's tied to a percentage of the Medicare price in that market in order to help to control costs there. So I think those are encouraging signs. And on the federal level, I think there are several kind of small things that may not get a ton of attention, but I think could have a big impact. If we go back to the drug space, the FDA recently has loosened its requirements on getting an interchangeability designation for biosimilars. And this is going to have a huge impact on biosimilars being able to gain market share. They don't have to do these switching studies where they switch the patient back and forth between the branded drug and the biosimilar in order to prove that they're the same level of efficacy. Because the fact is, over the last 15 years, we have enough data, we have enough time and research to know that biosimilars are just as effective and safe as the reference biologic product. There really shouldn't be an interchangeability designation in the first place. Europe a couple years ago put out a scientific statement saying we don't need this. And again, Europe is ahead of the US on this, as they are in a lot of different drug policies. And so I'm encouraged by, some of those regulatory decisions. And I'm encouraged with this new incoming administration that I think they're going to want to do certain things in the healthcare space through executive orders. But I also think that there is space for larger healthcare reform. You do have several Republicans that have their own plans on how to do this, and not just address the number of uninsured, which some of these plans do that as well, and that is important, but really seek to address the pricing problem and try to actually lower costs for not just a certain segment, whether it's Medicare or what have you, but for all Americans.
So okay, we've settled on we're gonna get on this pricing thing. There's a huge bubble of fat there, and let's boil it down. So we have two problems, right? We don't know what prices are, so we have a transparency problem, and then we have an agency problem. What makes me go to the cheaper one? And you could sort of the top down would say, price fixing. The government's just going to say, nope, everybody's just going to lower their price the way they do with Care and Cade. The other would be to say, nope, it'll be better if people actually move their market share around to the cheapest player. But how do you get that money when they move to the cheapest player back to the shopper, to the consumer? Self-insured employers have a little bit more agency and autonomy, but if you're the head of HR, say, this one's much better. So I'm going to tell all these people who are writing software for me where they're going to get their MRI or which doctors they're going to have. And they're like, what are you doing? How dare you, HR of my tech company, tell me about my health? And frankly, the HR person's like, you're right. How dare I? Do whatever you want. It's not worth losing people. Along comes ICRA, right? A way where people can maybe do their own choosing. And then, hey, I could imagine defining myself. I'd say, I'm a cheap healthcare guy. I only choose the cheapest products. I keep the money, and I don't mind driving 6 miles out of my way to get the low-cost MRI. What do you guys think is the right, out of that tapas bar, what are you choosing as your, or are there other dishes? What are going to make these price reveals turn into cost reveals?
Yeah, I think there's multiple layers to this onion. What's interesting, and Turquoise Health has put out some research, or a price transparency company, and they're looking at what's happening in the hospital marketplace with now that we're starting to see what the prices are. And what they're seeing is convergence. You see the top third most expensive dropping down. The last report was 6.3% adjusted inflation reduction in prices at the highest cost hospitals, and you are seeing some at the bottom come up. I think it's important for those of us that think a little bit more market oriented. It's not just about going to the cheapest. In fact, it's about going to the most valuable one. So, for instance, like our cell phones, we pay 10 more for our cell phones. Most of us think we get a lot more value out of it. So I think Americans in general will be more than happy to pay a lot. We just got to make sure that the most expensive providers are the best quality, have the best outcomes. Then they should get rewarded that way. It's not just about driving everybody to whatever the cheapest is.
Can we file that under transparency? Can you talk to us about what?
Yeah, you can. I've spent a lot of time. So I started in 2012 working on price transparency and have worked in a number of states and talked to price transparency companies all over the country. There's a couple of things that I think you need carrots and sticks. You do have to make a commitment to education to make sure the patients understand how to navigate the system. Only 30 to 40% of patients will ever shop. However, there is a ripple effect to that. It's about making new entrants into the market. I'm not going to steal. I don't know a ton about the drug space, but like as soon as you have a new drug enter the market, that's where you see the price go down. That's what we need in healthcare. You need more accessible options to come onto the market. We need more Southwest airlines, if you will, in healthcare to emerge, where it's easier to access the system. And I don't know exactly always what that looks like. Maybe it's coming to your workplace. Maybe it's telehealth is a version of that, but it's probably not the sole solution. It's got to be integrated in. When you want to use technology, you can use technology. When you want to go see somebody, you can go see somebody. You've got to make it as easy as possible, but also more affordable. And I think these all converge together when you have carrots and sticks. I agree with you, Jonathan, that most HR directors will say, I'd prefer you sit at your desk happy, and we'll pay a premium for that. But there is 30 to 40% of your population, especially as deductibles have continued to go up, which they have all over the country. People are going to have an increasing interest in seeking value. Now the question is, are the tools making it easy enough to find those? Is it easier to go to the lower cost option than the higher cost option? And I think we can get there, but regulators probably need to play some role for the top providers at the top, understanding why are they charging such high prices, which we were talking about briefly before, often is to fund their infrastructure, to keep those doors open. So asking some very hard questions about, do you need this infrastructure? Is there a service options available? And I'm not saying they dictate exactly how many of each resources are there, but it's more knocking down barriers so more entrants can come into the market so people can vote with their feet and get rewarded when they actually do vote with their feet.
I think in healthcare, we have spent a lot of energy trying to not make anyone worse off. And whether that's the benefits person who doesn't want to upset any single employee who wanted, whose favorite doctor got kicked out of the network, or whether that is federal policymakers, candidly, mostly on the left, right, who never want to make a cut that is going to make any one individual worse off. And in the meantime, we are all worse off, right? We've made everybody worse off. The healthcare is completely unaffordable, and we're making trade-offs every day that we just pretend don't exist, right? Because we're not making an active decision about them. And so, I guess I think that it is time that we have to accept that we are all worse off, and we have to start taking control of those decisions, which means that networks may get smaller, that we may not have, expansive health plans that cover every single provider. And I don't personally think that consumerism is the answer. There is some set of folks that are going to shop, but we have lots of years of evidence to say that people are relatively bad healthcare consumers for a bunch of reasons, right? Not only do they not have enough financial skin in the game, but actually, we're not all doctors. So whenever we make choices, we make the wrong ones for ourselves because we don't know what we need. And people don't want that, right? A lot of people do not want to spend more time being an active healthcare consumer. And so I do think that we need structures, whether it be through employer-sponsored insurance or other of these innovative benefit designs, to help guide folks to high-value, lower-cost providers without putting so much onus on individuals.
And to, again, go off these comments, I do agree that consumerism does play a role, and it will play a significant role for a subset of the population who's willing to do that. I think at the same time, all the consumerism in the world does you no good if, for example, within the hospital space, if hospitals continue to rapidly consolidate like they are and gain all kinds of pricing power over the payers. This is a huge problem that is going on. We have multiple, many major metro areas in this country where you have one or two providers that exercise all kinds of pricing power over the insurers because they have no choice but to include those in the network if that insurance plan is to be viable. So, and there are numerous studies showing how that kind of consolidation leads to higher prices for those services. And so we need to address that problem. Now, there are a lot of good ideas to limit the amount of consolidation that continues from here on. The anti-competitive contracting practices I was talking about on the state level is a very important part of that, prohibiting those. And also, I think there's a role to, simply repealing the prohibition in the ACA on physician-owned hospital formation. We could do that very easily, and I think that's a no-brainer. But part of the way to deal with this is we have to also deal with the consolidation that has already occurred, and that's a much more difficult nut to crack. On that point, we at FREOPP, our idea on this would be to borrow, Josh talking about carrots and sticks. What we would do is you basically have a proposition to each of these hospital systems. You say, okay, you're a heavily consolidated hospital system. You have two choices. You can either voluntarily divest and break yourself up, or you can accept X percent of Medicare rates for all of your privately insured patients. Whether that's 100%, 125%, you can figure out what that number is going to be. But I can almost guarantee you that based on that number, the hospital is much more likely to choose the former rather than the latter. Some of them may choose the latter if it makes sense for them. But if they could just break themselves up and then they're allowed to charge whatever price they want, we're instantly going to get a more competitive market. Now, I would say that, there's that part, but then there's also the vertically integrated part of this, where the hospitals are acquiring physician practice. Vast majority of physicians now are employed by hospital systems now, which is a huge problem, driving up prices. One area in particular where, again, there's state action on this, and I think there's momentum on the federal level to deal with this, is what we talk about when we call it site-neutral payment. So it's basically, in lay terms, a hospital charges a facility fee even if you're visiting a doctor in a normal office setting. Just because that doctor's employed by the hospital, they'll charge a hospital facility fee as if you're going to an outpatient procedure, inpatient, or the ER. So that is very low-hanging fruit that there is some bipartisan consensus to deal with. And if you remove those facility fees, if you prohibit those, you remove a lot of the incentive for the vertical integration acquiring these physician practices. It's not going to do away with all of it. There's a lot of physicians that, quite frankly, are totally fine with being employed by a hospital. They don't have to run their own practice, and that's fine. But it will deal with some of that, those perverse incentives that are driving up prices.
You had a little reaction there.
Well, I think site neutral is the important first step. Agreed. We have to also acknowledge, though, there are 340B incentives driving vertical consolidation. And who's
you want to quickly describe this fabulous legal
340B?
Kickback? Yeah.
Quick, you only have 20 seconds.
20 seconds. 340B is a program in which effectively drug companies subsidize hospitals, a certain set of hospitals that are providing a disproportionate amount of uncompensated care, or at least that's how the story goes.
Yeah.
That program has grown significantly, and so when a hospital acquires a physician practice, and including all, like an oncology practice and all the drugs they're giving, they then begin to be able to buy at 340B prices, and their spread increases significantly. So another financial incentive for vertical integration. But then and then we shouldn't just, because we don't want to just beat up on hospitals, we should point out that the single largest employer of hospitals in the country is United Health Group. So the plans are in the game too.
Yes, indeed. And so we've talked a lot about consolidation and then wrestling with these behemoths. We haven't yet talked about new entrants. So one way to lube up a sclerotic market is to get new players on the outside that are maybe employing doctors and providing the convenience and lifestyle of employment, but aren't stuck with the fixed costs and the vertical monopoly, and maybe even make money through savings. Talk about, we had a digital health kind of funding boom in 19, 20, 21, and then we've had a sort of a normal dying out in 22 and 23, but there remain thousands of new entrants that are not tied to these monopolies on the payer side and on the provider side. There are payviders, Firefly Health, I'm on the board of. They're a full Kaiser, but you're primary care doctors inside of an app, and they navigate you to that MRI that's cheaper by giving you no copay. Have you guys noticed any impact from all these newly shiny funded digital kind of non-terrestrial new entrants?
I'll kick us off since we're doing a lot of work on this, and then I'm eager to hear your guys' take. So we launched the Peterson Health Technology Institute last year, really in response to the phenomenon, Jonathan, that you just laid out, which is, there's been a ton of VC investment in digital health companies. COVID pandemic really accelerated the adoption of those technologies. And, when we started talking to folks in about 2022, whether it's employers, health plans, or large health systems that had adopted these solutions, to a person, they all said, I have no idea if this is making anyone healthier. I think it's probably driving up costs, but I can't really suss it out. The ROI analyses are, amazing, but don't seem to be playing out. And we have very little evidence about what kind of outcomes we're getting for any of these tools. It was just a market that grew wildly and quickly and without sort of the discipline that you have in the drug space, right, with FDA approval and the sort of expectations around evidence. So, we started doing reviews of digital health solutions. We have done 3 so far on sort of a dozen companies each in diabetes, hypertension, and musculoskeletal. And, what's interesting is actually people, when we started, said, you're not going to be able to do this. You're not going to be able to assess clinical efficacy of these solutions because there's no evidence. Untrue. There's tons of evidence, but nobody sells on it because they haven't needed to, right? If you're a VC-backed founder in the digital health space, it's been much more efficient for you to invest in sales and marketing than in evidence generation. And we've had great companies with great evidence that then can't get market share and go out of business. So there's just no connection between performance and evidence and outcomes right now. And so we are trying to change that. I think folks are starting to see the change, but at the moment, technology has the potential to solve a lot of these problems. Right? We have workforce problems. We've got chronic care management problems. We've got a slew of problems with lots of opportunity for technology, but we have to actually measure the performance, and we have to hold them accountable for delivering on some sort of economic outcome with that investment. And neither of those things have been true today. I believe they're going to be more true in the future.
And gut call on the studies so far. Does the category have hope in it?
Absolutely. Actually, it's a mixed bag, right? We don't want to be like just an industry crusher. That we have no incentive to do that. But the answer is actually you have to look, and it's mixed, right? So we saw the diabetes solutions. Diabetes management is really hard. Prior to GLP-1s, we're not that good at it in brick and mortar settings. And shockingly, when you transfer it to a digital setting, nothing magical happens. People don't get that much better. Virtual musculoskeletal solutions, the virtual PT apps, they work great. They are equally effective as in-person PT for a huge portion of patients that allows you to do it at home, save the transportation, and solves a workforce shortage in a lot of sort of rural and other areas. Huge opportunity. And then the most recent report on hypertension was interesting. It was mixed. A lot of solutions that do not deliver any benefit over usual care in terms of reducing blood pressure. The solutions that worked best were integrated into primary care clinics, but then used virtual prescribing teams to actually do medication management and titration. It's a really easy use case for a virtual team, and it brings a lot more capacity to the primary care setting. So you have to actually know what the intervention is and how you're deploying against it, not just say, we've got a whiz-bang solution that's going to bring your blood pressure down.
I would add to this, looking at other technologies like AI in healthcare. This is kind of the big thing that's kind of coming to the fore, and I think it has some potential to lower administrative costs, particularly among insurers, to streamline some of those processes, to process claims quicker, and those kinds of things, which would always be a good thing. But a word of caution on that, and that is that there's going to be bugs that have to be worked out in the system on this, because recently the publication Stat put out an investigative reporting on this that showed that UHC had kicked people out of skilled nursing facilities far earlier than they should have been. They were not ready to leave because basically the algorithm told them to, and so there have been some really negative reports on that. So this is going to have to be worked out over time, but it does have some potential to sort of take care of some of those menial tasks that we're employing a lot of people for, adding a lot of administrative costs to the system, and just help to kind of lower that and not negatively impact the patient experience either. But it needs to be worked out.
I just want to give the counter example to the United Health Group example. So the New York Times, I guess this weekend it came out, study on the diagnostic performance of a doctor alone, a doctor with an AI solution, and the AI alone. And the AI alone the doctor with the AI solution and the doctor alone perform almost exactly the same. And the AI outperforms them dramatically, which means that the doctor with the AI tool gets the correct answer and in their judgment overrules it and gets it wrong a good percentage of the time. So my point is only, I think as humans, it is natural for us to gravitate to places where AI errors, and those places absolutely exist, but we are also deeply flawed and err a lot. And so, I think there's a lot of potential and we need to be thoughtful about it.
And the research really needs to be done. I mean, like actual, clinical trial data should be done on this to explore it.
And I think we also recently, came out with research that smarter people screw up even more, right? That wasn't there that self-deception is more powerful following your hypothesis despite counterfactuals is more common among smarter people. So doctors are actually worse than even average, steam fitters at making the right clinical decisions in some circumstances. It's illegal to fly a plane yourself over 18,000 feet. The data is so clear that the autopilot is so much better that it never just gets bored, and it keeps you within 2 feet as opposed to 200.
Can I just add to your earlier question about new entrants? To give folks a sense of how low the bar is at the state level, that we're fighting over things that I think are just absurd to prevent new entrants in. Certificate of need laws. This is like McDonald's getting to weigh in on whether Burger King opens or not. You have hospitals vetoing new entrants into the market or others. We have licensing issues. I mean, the way we treat medical professionals licensing-wise, if we did that to pilots, you could fly here, but you couldn't take off. There wouldn't be enough pilots. Like, we have to address these very low bar issues to allow new entrants to come into the market and scale more quickly. And instead, we get these political fights. Where I've seen the most innovation has actually been outside of the status quo. The analogies between education policy and health policy is actually really interesting right now, because there's this whole cash pay market, or the sharing ministries, or crowd health, or farm bureau plans in, I think, 9 states that allow you to finance in a different way than the traditional plans. It's still a very small piece of this market, but I think it's going to be interesting to see how that emerges over time, whether more and more Americans are drawn to it. But then we have these quality questions, like how do we gauge whether people are getting better outcomes going into the cash market, because we won't have as much data. My argument, though, is embrace it, because the current status quo is not delivering really well. And so we need to at least try new things, remove some of these lower barriers.
Our last 2 topiclets, the studying results and maybe that net these digital new players outside of the vertical Borgs would be useful. Both bring to mind data, the actual integrity of information and the ability to study it across many providers. So if a patient moves around to these new people, how do you see the whole picture? How do you study when all you have is claims data? Whether that person was really sicker, et cetera, et cetera. Where are we in the kind of, I hate to use the word interoperability, but the federation of health data, and what are our prospects?
I think that we have more health data available to us than we ever have before. thanks in large part to the price transparency information, which I do think is, and some pressure, some sort of CAA related pressure to give employers access to their own data. So I think the access to data is improving. I would say stitching it all together and making meaning out of it remains highly challenging. We're doing a lot of work in this space, but we're not there yet. And I personally am concerned about the commodification of that data, right? That data has huge value. You're seeing sort of health plans trying to lock up their data, providers trying to lock up their data because it's a huge revenue opportunity. Yeah. And, as a country, if we let that data just be sold to the highest bidder, we're going to lose a lot of information from it.
Other comments on data?
I would say that there, again, going back to the states, there's some good work being done by state governments to try to gather more of this data, in particular the all-payer claims databases, and to make them more useful. I think that's the kind of the next frontier on this. Is we've got several states that are doing this. They're collecting all this data, but it's not very useful. It's not very accessible even by researchers. And so I know in Texas, they're looking to make some movement on this in the next session where the data can actually be accessible and researchers can get their hands on it to be able to really answer some of these important questions on prices and quality. And so that can be, disseminated to the wider public so that we can kind of from the ground up get, the kind of policies we want to see.
Can I just say one thing? There was research a couple of years ago that was talking about how long does it take from a best practice being identified to spreading through the medical community, and I think it was, 17 years? You know what that roughly correlates with? A whole new brand of medical students graduating and getting into practice. So we've got this bigger issue. I hope data gets us there where we can find out what works and doesn't, but we've got like a dissemination problem in the medical community where a best practice gets identified and it takes forever to actually spread. And so we got to figure that piece out too.
I would add to that real quick, or the best practices that are spread are not really best practices because the powers that be say, oh, we should do it this way without any kind of evidence. One of the prime ones is the recommendation from the Pediatrics Association to not give peanuts to kids under the age of 3. And we've seen an explosion in peanut allergies because of it. And it was based on zero evidence. It was like they just decided that this was the way we were going to deal with it. And we're dealing with the consequences of a really bad recommendation.
Fetal monitoring for women. I mean, the taking fat out of food and putting sugar instead. Wow. Yeah. Okay. Let's go to the fabulous studio audience.
This is sort of a story as much as a question, kind of a commentary maybe. When I first started doing medical oncology, most of the chemo, this is in the late 70s, early 80s, chemotherapy was primarily given in the hospital, and then gradually it moved out of the hospital into the outpatient setting, and we and primarily, unfortunately, I have to say, oncologists reimbursement primarily depended upon their chemotherapy, and they made the money on the drugs primarily. There's no facility fee, for oncologists. But we gradually developed a very large facility, had the best nurses poached from the hospital, a large, team of nurses. We could basically treat almost anything as an outpatient, virtually. We didn't have to admit much to the hospital. Patients with no counts, they'd, come in, get their antibiotics every day, blood cultures. Patients with sepsis would get treated as an outpatient. And then under when under President Bush and Karl Rove, when they instituted Medicare, reimbursement for prescription drugs, they also cut back substantially on chemotherapy reimbursement, which meant that oncology practices basically could no longer almost no longer survive in a lot of instances. I mean, many did, but many could not survive anymore. And eventually we were purchased by Yale, and we were given a little speech the day that the integration took effect, as to what we would tell patients, why their bill was, instead of $2,000, it was $20,000, and that was going to be okay. Don't worry about it. They would, because now Yale could make money where we couldn't because of 340B pricing and facility fee. So what we did for $2,000, $3,000, $4,000 now became $15,000 to $20,000 a visit. Giving somebody nivolumab or pembrolizumab every couple of weeks became a $20,000 visit instead of a $3,000 or a $4,000 visit. So that whole system got wiped out, and it's just the same care. There was nothing different in the quality of care. Nothing changed. The nurses stayed the same. The doctors stayed the same. The facility stayed the same. But the care, tripled in price. And
there is sort of a wall of fame, #shame, of well-meaning policies in the last 30 years that mitigated towards vertical integration, that mitigated towards vertical monopolies. And I think the well-meaning, good, constraint on prices there was foiled by the hospital, lobby slipping in this 340B gimmick and turning a good thing, which is putting everyone under pricing pressure, into a monopoly. Another one was electronic medical record mandates. The way it was pushed out, doctors looked and said, I can't do all this. And the hospital said, no problem, come on in. And we went from 27% of doctors working for a hospital in that period to 80, I don't know the number now, it used to be 84% of doctors. So amen, brother. That's why there's FREOPP. Thank you for your support. Any other reactions there, or should we go? Oh, do we have Joel? Go ahead.
So actually, my question is very similar. If you assume that most patients are not going to do their own shopping and that they're going to get their PCP's recommendations, and the fact that most PCPs are employed, the question is, what can we do to actually reverse the employment trends?
Yeah, the variety of options here. I'm not sure any of them are going to be terribly satisfying. I think. I think one of it is starts in medical education training. Like the fact that most of them aren't even thinking about running their own business is a potential problem. And so there's probably opportunities there to at least put that in front of them and say, this is an option. You can do this. I think the direct primary care explosion, if you will, still relatively small in the grand scheme of things, but like there's growing interest, and the price transparency companies that I talk to, they talk a lot about just making sure the on-ramp on is right. Once your referring physician is you look at the referral patterns and they tend to refer to high value providers, then they feel much, much better. So I think there's an education piece on when a new employee comes in or other, how do you make sure that they're getting their primary care provider that's referring in at least cost-conscious ways going forward. Some of these scope of practice or other licensing reforms at the state level would be helpful in allowing people to open new offices or expand their independent practices. I think there's a couple of these opportunities that at least open the door to having more and more of them go back into independent practice.
I think going off of some of the things we've said, and again, you gotta remove the incentives that exist there. The facility fees is a big part of that. But I agree to Josh's point, and part of it is just letting doctors know that this really is still an option, and it could be a good option for you, is also part of it. But just letting doctors know that yes, this is an option, but in the end, owning their own practice, running their own practice, rather than being vertically integrated with a hospital. But ultimately, you've got to deal with a lot of the financial incentives that are leading for hospitals to acquire these practices. And again, part of it is just having also just more competition among hospitals too, horizontally, allowing physicians to form their own hospitals, outlawing that in the or removing that was in the ACA, and just removing incentives like that are leading to the vertical integration.
I think both those suggestions are the best we have. I mean, the challenge really in thinking that we're going to have a lot of docs go back to primary care or primary practice and practice ownership is like they don't have an out, right? Who do you sell your practice to when you're ready to retire in an era where you've got most doctors in employment models? If you don't have a doc that wants to take over your practice, your options are hospital or PE. So I think some of the things that Gregg mentioned are likely better solutions.
We're out of time. I'll throw in, there is a movement worth studying of recently acquired doctors breaking out and forming separate corporations, private equity-backed companies. They play in the accountable care space, so they try to set themselves up to make money from savings. So far, they've mostly made money from upcoding the sickness of their patients, which that was the game that was laid. I think at some point that's a regulatory opportunity, and then there's a lot of money to make, as we've just described, cutting price, et cetera. Thank you all very much, and looking forward to the next session.